Pneumonia. Pneumonia is a acute inflammation of the lung parenchyma caused by microbial organisms. The discovery of sulfur drugs and penicillins was pivotal in the treatment of pneumonia. Pneumonia, it is an inflammation of lung parenchymal cells. Risk factors or risk groups: immunosuppressed patients, that are old age, under 5 children, performed organ transplantation because they are taking immunosuppressed tablets for prevent rejection. Common causative agents are Staphylococcus, Streptococcus, Pseudomonas aeruginosa, Enterobacter MRSA. Etiology. uh, Factors predisposing to pneumonia: aging, air pollution, altered consciousness, alcoholism, head injury, seizure, anesthesia, drug overdose, stroke. Altered oropharyngeal flora secondary to antibiotic, prolonged bed rest, prolonged immobility, chronic diseases due to pneumonia, chronic lung disease, DM, heart disease, cancer, end-stage renal disease, debilitating illness, HIV infections, immunosuppressed drugs, inhalation or aspiration of noxious substance, intestinal and gastric feed via nasogastric tube, malnutrition, smoking, tracheal intubation, upper respiratory tract infection. These factors are predisposing to pneumonia. Types of pneumonia. There are types are chemical pneumonia, hospital acquired pneumonia, hospital acquired pneumonia. It causes ventilator associated pneumonia and iatrogenic pneumonia. Chemical pneumonia due to aspiration of inhalation of irritants. Staphylococcus and Streptococcus infection, transferred from droplet nuclei. Hospital acquired pneumonia. After 48 hours of hospital admission, it is nosocomial infection. Causes: methicillin resistant Staphylococcus aureus. Methicillin resistant Staphylococcus aureus MRSA. Mode of transmission is direct contact. It is two type: ventilator associated pneumonia. Ventilator associated pneumonia precautions: head and elevation, closed suction, mouth care. Use anti-embolism stockings, H2 receptor or PPI. Avoid administer humidified oxygen. Iatrogenic pneumonia, healthcare induced pneumonia due to lack of aseptic techniques. Drug of choice: vancomycin, linezolid. Drug of choice are vancomycin, linezolid. Contact precaution. Community acquired pneumonia. It will develop outside the hospital or first 2 days inside the hospital. Risk groups: overcrowded, overpopulation. The causes is mycoplasma pneumonia. No cell wall. Drug of choice is tetracycline. Pneumocystic pneumonia. Fungus infection. The causes is pneumocystic giardia. Opportunistic infection mainly occur in AIDS patient. Drug: dapsone, clindamycin. Prevention: hypostatic pneumonia mainly occur in bedridden patients due to pooling of secretion in the lungs. Management is usually spirometry and change position frequently. Diagnosis: chest X-ray, sputum culture, CBC and ECR. Clinical features of hypostatic pneumonia: high grade fever, productive cough with rust colored sputum, chest tightness, pride or crackles, decreased blood sound, use of accessory muscles of breathing, tachycardia, dry mouth, bronchi. Prevention: pneumococcal vaccine, Streptococcus pneumonia. Management: priority for airway clearance. Administer humidified oxygen to loosen the secretion. Take much more water. It will help to loosen the secretion. Every 2 hours, change the position of the client. Practice deep breathing and coughing exercise. Use incentive spirometry. Chest physiotherapy followed by postural drainage. Suctioning. Position. Semi-flawless position. Monitor saturation. Diet. High calorie and protein with a small amount of frequent meals. Complete the bed rest and increase the activity gradually. Drugs. Antibiotics, bronchodilators, mucolytic, expectorant, analgesics. Nursing diagnosis. Ineffective airway clearance. We will discuss pneumonia in detail. Pneumonia. Pneumonia is an acute inflammation of the lung parenchymal caused by microorganism. Organism associated with pneumonia. Community acquired pneumonia, Streptococcus pneumonia, Mycoplasma pneumonia, Haemophilus influenza, respiratory virus, Chlamydia pneumonia, oral anaerobus fungi. Hospital-acquired pneumonias are Pseudomonas aeruginosa, Enterobacter, Escherichia coli, Klebsiella, Staphylococcus aureus, Streptococcus pneumonia. Pathophysiology. Due to aspiration of Streptococcus pneumonia, release of bacterial endotoxin, it leads to inflammatory response, attraction of neutrophils, release of inflammatory mediators, accumulation of fibrous exudates, red blood cells and bacteria. That will lead to red hepatization and a consolidation of lung parenchyma. It will leads leukocytes infiltration and neutrophils and macrophages, gray hepatization and deposition of fibrin on pleural surface. It will lead resolution of infection. Macrophages in alveoli ingest and remove the dangerous neutrophil, fibrin and bacteria. Resolution, complete resolution and healing occur if there was no complication. The exudates become lysed and processed by the macrophages. The normal lung tissues is restored and the person gas exchange ability return to normal. Clinical manifestations are dull of percussion, increased femiters, bronchial breath sounds and crackles may be found. Complications are pleuritis, pleural effusion, atelectasis, bacteria, lung abscess, emphysema, pericarditis, meningitis, endocarditis. Most cases of pneumonia generally run an uncomplicated course. However, complications can occur and they develop may frequently in individuals with underlying chronic disease and other risk factors. Complications may include are pleurisy. Pleurisy, that means inflammation of pleura. It is relatively common. Next one is pleural effusion. Transudate fluid in the pleural space. Atelectasis, it means collapse or airless alveoli. It is one or part of one lobe may occur. These areas usually clear with the effective coughing and deep breathing. Bacteremia. Bacteremia means bacterial infection in the blood. It occurs in 30% of patients with a pneumococcal pneumonia and are associated with a 20% of mortality rate. The rate can go as high as 60% in elder patients. Lung abscess is not a common complication of pneumonia. It is seen in pneumonia caused by Staphylococcus aureus and gram-negative pneumonia. Emphysema, it is accumulation of purulent exudates in the pleural cavity. It is relatively infrequent but require antibiotic therapy and drainage of exudates by chest tube or open surgical drainage. Pericarditis result from spread of the infection or infecting organism from an infected pleura or via the homogeneous route to the pericardium. Meningitis, it can be occurred by Staphylococcus pneumonia. The patients with pneumonia who is disorientated, confused or should have a lumbar puncture to evaluate the possibility of meningitis. Endocarditis. Endocarditis can develop when the organism attack the endocardium and the valves of the heart. The clinical manifestations are similar to those of acute bacterial enteritis. Complications: pleurisy, pleural effusion, atelectasis, bacteremia, lung abscess, emphysema, pericarditis, meningitis, endocarditis. What are the diagnostic measures and collaborative treatment of pneumonia? We will discuss in diagnostic measures. Diagnostic tests include history, physical examination, chest X-ray, gram stain of sputum, sputum culture, and sensitivity test. If you're doing in sputum culture and sensitivity test, if drug-resistant pathogen or organism not covered by empiric therapy. Pulse oximetry or ABG, complete blood count, differential and routine blood chemistries if indicated. Blood culture also done. Collaborative therapy it include antibiotic therapy, include fluid intake, increased fluid intake, limited activity and rest, antipyretic analgesis, oxygen therapy. Collaborative care. Prompt treatment with the appropriate antibiotic almost always cure bacteria and mycoplasma pneumonia. It is uncomplicated cases. The patient respond to drug therapy within 48 to 72 hours. Of indications of improvement include decreased temperature, improved breathing, and reduced chest pain. Abnormal physical findings can last for more than 7 days. In addition to antibiotic therapy, supportive measures may be used including oxygen therapy to treat hypoxemia, analgesis to relieve the chest pain for patient comfort, and antibiotics such as aspirin or acetaminophen for significantly elevated temperature. During the acute febrile phases, the patient's activity should be restricted and rest should be encouraged and planned. Most individuals with a mild to moderate illness who have no other underlying disease process can be treated on an outpatient basis. If there is a serious underlying disease or the pneumonia is accompanied by several dyspnea, hypoxemia, or other complications, the patient should be hospitalized. Currently, there is no definitive treatment for viral pneumonia. Two antiviral drugs, amantadine and Remantadine, are approved to use within 48 hours of onset of symptoms in the treatment of influenza A virus. Pneumococcal vaccine. Pneumococcal vaccine is indicated primarily for the individual considered at risk who has chronic illness such as lung and heart disease and DM. It is it is recovering from a severe illness. A 65-year-old age, a old age people, or is in a long-term care facility. They are particularly important because the rate of drug-resistant Staphylococcus pneumonia infection is increasing. The vaccine is 50% to 80% effective in preventing bacteremic pneumonial disease. In immunosuppressed patients, individuals are risk for development of fatal pneumonial infection. A second dose is recommended after 5 years, although the efficacy of revaccination is unknown. Drug therapy. The main problems with the use of antibiotic pneumonia are developed of MDR organism and the patient hypersensitivity or allergic reaction to certain antibiotics. Most cases, CAP or otherwise healthy adult do not require hospitalization. The oral antibiotic therapy administered is frequently empiric treatment with a broad spectrum antibiotic. Once the patient is categorized, empirical therapies can be based on the likely infecting organism. Nutritional therapy. Nutritional therapies include fluid intake of at least 3 liters per day is important to supportive treatment of pneumonia. If the patient has heart failure, fluid intake must be individualized. If oral intake cannot be maintained, IV therapy and electrolytes may be necessary for the actually ill patient. Weight loss often occurs in the patients with pneumonia because of increased metabolic needs and difficulty eating due to shortness of breath and pleuritic pain. Therefore, it is important to provide nutritional intake to meet the needs of the patient. Small frequent meals are better tolerated by the dyspneic patient. There are many nursing interventions to help prevent of the occurrence of the as well as the morbidity associated with the pneumonia. Teaching the individual to practice good health habit such as proper diet and hygiene, adequate rest, and regular exercise can maintain the natural resistance to infecting organism. If possible, exposure to upper respiratory tract infection should be avoided. If a upper respiratory tract infection occurs, it should be treated promptly with the supportive measures. If system if symptoms persist for more than 7 days, the person should obtain medical care. The individual at risk for pneumonia, chronically those who are chronically ill patient or older adults should be encouraged to obtain both influenza and pneumococcal vaccination. In the hospital, the nursing roles involve identify the patient at a risk and taking measures to prevent the development of pneumonia. The patients with the altered consciousness should be placed in position, example sideline or upright position, that will prevent or minimize the risk of aspiration. The patient should be turned and repositioned at least every 2 hours to facilitate adequate lung expansion and to discourage pooling of secretion. In VAPS, a significant reduction in pneumonia incidence is found when patients are placed in a semi-competent position. It is recommended that intubated patients be in semi-recommended position 30 to 40 degrees, particularly during enteral feeding. In intubated patients, the ATS associate also recommended continuous aspiration or subglottic secretions above the tracheal tube coughing using a specially designed endotracheal tube to prevent the risk of VAP. Ambulatory and home care. The patient need to reassure that complete recovery from pneumonia is possible. It is extremely important to emphasize the need to take all of the prescribed drugs and to return for follow-up medical care and evaluation. The patient need to be thought about that any drug and food drug interaction for the prescribed antibiotic. Adequate rest is needed to maintain progress towards recovery and to prevent relapse. The patient should be told that it may be weak before the usual vigor and a sense of well-being are felt. A prolonged period of convalescence may be necessary for the older adult of chronically ill patient. The patient considered to be at risk for pneumonia should be told about available vaccines and should discuss them with the healthcare provider. Deep breathing exercise or incentive spirometry therapy should be practiced for 6 to 8 weeks after the patient is discharged from the hospital.